About 40% of new graduates miss the midline. This results in excessive bleeding from the skin and often fascia. To prevent this, you can use a surgical marker. Up to 1% will push the urethra over the testicle when squeezing, resulting in damage to the urethra. 50% will struggle to stabilize small testicles, making the incision offline. Use 3 fingers to stabilize the testicle, 1 finger on each side, and the third finger to stop the testicle slipping back. Most graduates will accidentally cut through the tunic. If you are unsure whether you have reached the tunic, push the testicle backwards and forwards. The tunic will move with the testicle. Tear away the attachment to the testicle. Use a swab to give a better grip. It's like tearing open a sachet of ketchup. Do not be tempted to cut with scissors. Once the attachment has broken, strip down the fat by rubbing down the tunic. 20% of new graduates will damage the cremasteric vessel, resulting in bleeding, which should not be a concern, unless the bleed is very close to the body. The tunic is now opened, converting from a closed castration to an open. 35% of graduates will accidentally cut through the testicle, but don't worry, this is not a concern. There will just be more bleeding. Tear away the attachments to the testicle. Use of a swab will help with grip. With this technique, you can cut the attachment with scissors, especially if it is an older dog and really tough. To stop the testicle slipping around, I use a clamp or Alice tissue forceps to fixate, making ligature placement easier. I usually place a surgeon's knot, followed by a miller's knot. About 20% of new graduates can snap the ligature, or slip off the ligature when tightening. This will result in a tug. For 2%, this tug can snap off the testicular vessel. The snap occurs at the position of the knot, and the unligated part slips back into the body. The mistake can be lethal if you don't enter midline and ligate the broken vessel. Vascular bleeding is not evident because the bleeding occurs inside the body. The next ligature is a miller's. Keep it close to the surgeon's, so we don't have too much dead tissue. Most new graduates place forceps to make a crush bed. They sometimes use an aggressive clamp, like a Rochester, and for 2% of them, they damage the testicular vessel, or cremasteric, resulting in massive bleeding. Avoid making crush beds. On risks vs benefits, they are not needed. Only consider a non-aggressive like a Carmelt clamp. If there is bleeding, you must get a ligation below. Most new graduates place 3 clamps before starting. The problem with this is that it can result in engorgement of the tissue. This can then result in increased pressure, making tight ligatures more of a challenge. Keep life simple and use just 1 clamp. So the testicular vessel and cord have been ligated. These are now slid deeper in, and now we ligate the tunic. This also includes the cremator muscle and its vasculature cremasteric vessel. Most painful swollen scrotal hematomas form due to failure to ligate the cremasteric vessel. I usually place a miller's, which ligates the tunic, cremaster muscle, cremasteric vessel. Try and nudge the pedicle back through the ring and return any fat back inside the wound. 20% of new graduates will cut the fat away. This results in excessive bleeding and should not be done. Everything is now repeated for the other testicle, with the only difference being there is less tissue to incise to reach the tunic. Many new grads want to trim off any stringy fat from the wound. I have tried this in the past and has resulted in surprisingly heavy bleeding, so just push the fat back in through the incision site from which it originates. On closing the first layer, over 50% of new grads will get the fat caught in the suture pattern. Make sure the fat is returned before closure. Getting the fat to stay inside can be surprisingly difficult. You have made 2 incisions, so 3 pieces of tissue need closing: the far side, the middle raft, and the closest side. Tie off end close with a continuous pattern. If there was a degree of bleeding from the fascia layer, only then would I consider a simple interrupted pattern. Nearly 50% of new graduates will leave the knot and go straight into intradermals. It is important to hide or flatten the knot, otherwise it will stick up through the wound. I tend to take a bite cranially away from the knot, but towards the wound, exiting intradermally with the needle. Then continue with an intradermal pattern to the end. Some surgeons will leave a small hole at the end. This is used to make burial of the knot easier. Burial of the knot is essential, otherwise the knot can sit between the skin, preventing edge-to-edge healing, resulting in wound breakdown 2 to 3 weeks post-op. Over 40% of new grads fail to bury the knot, and the wound opens at the knot site in about 3 weeks. To help burial, try and leave a small hole at the end. Make sure the needle passes easily. If there is much resistance, go again. For burial, don't pull too much on the suture or it will snap. Instead, try and use your Adson forceps to push the skin over the knot. If you cannot bury the knot, pull the needle back out and try again. If all else fails, then cut off the needle and use a larger needle. This will create a passageway for the knot to bury.